Greetings to all of you. There is going to be a big boat race festival to be held in Brampton, to which we are happy to invite all of you. The festival is called Brampton Boat Race and is going to be held at the Professor's Lake, Brampton. This festival is being held every year for the last 10 years. This is a very colorful festival where you can come and enjoy with your family and friends. The great news is this year a number of multicultural communities will be participating in this boat race festival, which is great joy for all of us. We invite you all to come over and support your team. What is exciting is that you can actually form your own team of 11 members and participate in this Brampton boat race. We will provide you with all necessary equipment and the boat. If you want to compete in this boat race with your team, kindly register by the 19th of August 2021, which is the last date to submit your application. You may contact us on 001-647-917-5464, or you may visit our website www.bramptonfestival.ca or www.bramptonboatrace.ca. Again, this boat race festival is being held at the Professor's Lake, Brampton, Ontario on 25th August 2021, Saturday from 10 a.m. to 5 p.m. And we invite you to be part of this colorful Brampton boat race festival. Thank you.
നമസ്കാരം. ഇന്നത്തെ നമ്മുടെ ഡോക്ടർ ലൈവ് ആരംഭിക്കുകയാണ്. 47ാമത്തെ ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ ഡോക്ടർ ലൈവ് ആണ് ഇന്ന് നടക്കുന്നത്. കഴിഞ്ഞ 47 ആഴ്ചകളായിട്ട് ലോകത്തിന്റെ വിവിധ ഭാഗങ്ങളിലുള്ള അതിപ്രഗത്ഭരായ ഡോക്ടർമാരെ നമ്മുടെ ക്ഷണം സ്വീകരിച്ചു വരികയും നമ്മുടെ കമ്മ്യൂണിറ്റിക്ക് ആവശ്യമായ രീതിയിലുള്ള ഹോമിയോപ്പതിയെ, മറ്റ് നാച്ചുറോപ്പതി, മറ്റ് എല്ലാ വിധത്തിലുള്ള ഡോക്ടർമാരെയും കൊണ്ടുവന്ന് അവരുടെ എല്ലാം വിദഗ്ധ അഭിപ്രായങ്ങൾ കഴിഞ്ഞ 47 ആഴ്ചകളായിട്ട് നമ്മൾ കേട്ടുകൊണ്ടിരിക്കുകയാണ്. സമാജം ഇങ്ങനെ ഒരു പരിപാടി ആദ്യം സ്റ്റാർട്ട് ചെയ്തപ്പോൾ പലരും ചോദിച്ചു എന്തിനാണ് ഡോക്ടർ ലൈവ്, ഇതിൻ്റെ ആവശ്യം എന്താണെന്നൊക്കെ ചോദിച്ചു. പക്ഷെ പിന്നീട് ഇങ്ങനെ വന്നപ്പോൾ ആളുകൾക്ക് ഒരു ആവശ്യം ഉണ്ടെങ്കിൽ, തലവേദന ഉണ്ടെങ്കിൽ, നടുവേദന ഉണ്ടെങ്കിൽ, ഇപ്പോൾ കൊളസ്ട്രോളിൽ കുക്ക് ചെയ്യുമ്പോൾ ഓയിലിന് എന്ത് ചെയ്യണമെന്ന് അറിയാൻ വേണ്ടി, ഇങ്ങനെയുള്ള എല്ലാ കാര്യങ്ങൾക്ക് വേണ്ടിയും ആളുകൾ BMSന്റെ ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ പേജും ഫേസ്ബുക്ക് പേജും യൂട്യൂബ് ചാനലും ഒക്കെ എടുത്ത് നോക്കുന്ന ഒരവസ്ഥ, നോക്കേണ്ടുന്ന ഒരവസ്ഥ വന്നിരിക്കുകയാണ്. എല്ലാത്തിനെയും പറ്റി വിശദമായ ഒരു ഡയറക്ടറി ആയിട്ട് തന്നെ ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ സോഷ്യൽ മീഡിയ മാറിക്കഴിഞ്ഞിരിക്കുകയാണ്. അപ്പം ഇങ്ങനെ നമ്മൾ ഈ 47 ആഴ്ച ചെയ്തപ്പോൾ ഒരുപാട് കമ്മ്യൂണിറ്റിയുടെ ആൾക്കാരുടെ സപ്പോർട്ട്, എല്ലാ പ്രസ്ഥാനങ്ങളുടെയും സപ്പോർട്ട് ഒക്കെ നമുക്ക് കിട്ടിയത് വളരെ നന്ദിയോട് നമ്മൾ സ്മരിക്കുകയാണ്. എല്ലാ കമ്മ്യൂണിറ്റി നേതാക്കന്മാരും വിടുകയും ഗസ്റ്റായിട്ടൊക്കെ ഇരിക്കുകയും നമ്മളെ സപ്പോർട്ട് ചെയ്യുകയും അഭിനന്ദിക്കുകയും ഒക്കെ ചെയ്തിട്ടുണ്ട്. അപ്പം നമ്മളിപ്പോൾ നിൽക്കുന്നത് നമ്മുടെ ബോട്ട് റേസിൻ്റെ ഒരു നിർണായക ഘട്ട സമയത്താണ്. ഈ സമയത്ത് തിരക്കിനിടയ്ക്കും ഇത് മാറ്റി വയ്ക്കാതെ തന്നെ ഇത്തരം നമ്മൾ 47ാമത്തെ എപ്പിസോഡ് വരെ ഇതുവരെ നമ്മൾ കൊണ്ടുവന്നു. തുടർന്ന് നമ്മളെ കഴിവത്രയും മുന്നോട്ട് കൊണ്ടുപോകാൻ തന്നെയാണ് ആലോചിക്കുന്നത്. എന്നിരുന്നാലും ബോട്ട് റേസിൻ്റെ പ്രിപ്പറേഷനും കാര്യങ്ങളോടെ വരുമ്പോൾ നമ്മൾ ഒരു വർഷങ്ങൾ 1-2 ആഴ്ച ഹോൾഡ് ചെയ്യേണ്ടി വരും. നിങ്ങൾക്ക് എല്ലാവർക്കും അറിയാം, ഓഗസ്റ്റ് 21 വള്ളംകളി നടത്തത്തക്ക രീതിയിൽ നമ്മൾ കാര്യങ്ങളെല്ലാം ക്രമീകരിച്ച് പോയിരിക്കുകയാണ്. അപ്പോൾ ഇന്ന് നമ്മളെ അതിഥിയായിട്ട് വന്നിരിക്കുന്നത് അതിപ്രശസ്തനായ ഒരു ഡോക്ടറാണ്. ഇദ്ദേഹം കൊല്ലം ബേസ്ഡ് ഡോക്ടറാണ്. ഇദ്ദേഹത്തെ ലയൺസ് ക്ലബിൻ്റെ ഒരു ഭാരവാഹിയാണ്. ഇദ്ദേഹം വലിയ നിലയിൽ കൊല്ലത്തും കേരളത്തിലും ആകമാനവും അറിയപ്പെടുന്ന ഒരു ഡോക്ടറാണ്. ഇദ്ദേഹത്തെ നോക്കിയിട്ട് വളരെ ഭാഗ്യമെന്ന് തന്നെ പറയാം. അദ്ദേഹം കൊളസ്ട്രോളിനെ പറ്റിയും കുക്കിംഗ് ഓയിലിനെ പറ്റിയും ഫോർ ദ ഗുഡ് അതിനെപ്പറ്റിയുള്ള ടോപ്പിക്കാണ് അദ്ദേഹം പറയുന്നത്. അപ്പം ഇന്നത്തെ അദ്ദേഹത്തിന് ഞങ്ങൾ കിട്ടിയതിലും ഞങ്ങളോട് ചേർന്നതിനുള്ള സന്തോഷം ഞാൻ ആദ്യം അറിയിക്കുകയാണ് സമാജത്തിൻ്റെ പ്രസിഡന്റ് എന്ന നിലയ്ക്ക്. ഇന്ന് നമുക്ക് വിശിഷ്ട അതിഥിയായിട്ട് നമ്മളോട് എത്താമെന്ന് പറഞ്ഞിരുന്നത് നാഷണൽ ഫെഡറേഷൻ ഓഫ് മലയാളി അസോസിയേഷൻസ് ഇൻ കാനഡ, നഫ്മാസിൻ്റെ എക്സിക്യൂട്ടീവ് വൈസ് പ്രസിഡന്റ് ശ്രീമതി രാജശ്രീ നായരായിരുന്നു. പക്ഷേ എന്തുകൊണ്ടോ പുള്ളിക്കാരിക്ക് രാവിലെ കോവിഡിൻ്റെ വാക്സിനൊക്കെ എടുത്ത് അസ്വസ്ഥത വരാൻ പറ്റിയില്ല. അപ്പം എന്നാലും മാഡത്തിന് ഞങ്ങളുടെ സമാജത്തിൻ്റെ പ്രത്യേക കടപ്പാട് ആദ്യം അറിയിക്കുകയാണ്. പങ്കെടുക്കാൻ ചിലപ്പം ജോയിൻ ചെയ്യുമായിരിക്കും. എന്നാലും ചിലപ്പോൾ എനിക്ക് അത്ര തോന്നുന്നില്ല. രാവിലെ മെസ്സേജ് അയച്ചിരുന്നു, വരുമെന്ന് ഞങ്ങൾ പ്രതീക്ഷിക്കുന്നു. അപ്പം ഇന്നത്തെ മീറ്റിങ്ങിലേക്ക് സ്വാഗതം പറയാനായിട്ട് സമാജത്തിൻ്റെ ജോയിന്റ് ട്രഷറർ ശ്രീ സെൻ ഈപ്പനെ ഞാൻ ഈ അവസരത്തിൽ സാദരം ക്ഷണിക്കുന്നു.
Remembering all the world's healthcare workers lost to COVID, and a big thank you to all essential workers around the world, especially the healthcare workers during this pandemic period we are passing through. Pranamam. ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ 47ാമത് ഡോക്ടർ ലൈവ് പ്രോഗ്രാമിലേക്ക് എല്ലാവരെയും സ്വാഗതം ചെയ്യുക എന്നതാണ് എൻ്റെ കർത്തവ്യം. ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ 11ാമത് ബ്രാംപ്ടൺ ബോട്ട് റേസ് ഒരു മൾട്ടി കൾച്ചറൽ ഫെസ്റ്റിവൽ ആക്കുന്നതിൻ്റെ അണിയറ ജോലികൾ നടക്കുന്ന ഈ സമയത്ത് BMSന് വേണ്ടി എൻ്റെ ബോൺജൂർ, ഗുഡ് മോർണിംഗ്, സബഹൽ ഖൈർ ആൻഡ് നമസ്കാരം. I welcome the respected guest speaker, Dr. V. Balachandran. Our guest of the week, Srimati Rajashree Nair. She is not here today. She might come later. And chair of today's Dr. Live program, ഞങ്ങളുടെ നെടുന്തൂണായ ശ്രീ കുര്യൻ പ്രക്കാനം. Srimati Rajashree, she is an executive vice president of National Federation of Malayali Associations in Canada. Dear friends, on behalf of Brampton Malayali Samajam, President Sri Kurien Prakanam, and all other esteemed committee members and myself, Sen Epen, we would like to invite Dr. V. Balachandran for today's 47th Dr. Live episode of Brampton Malayali Samajam. Before we start the program, let me say a few words about Dr. V. Balachandran, who is hailing from Kollam, Kerala State. Dr. V. Balachandran is the chief physician at Dr. Nair's Hospital, Kollam, for the last 41 years. He was the best outgoing student in MBBS, MD, and MN AMS, which is National Academy of Medical Sciences. He was awarded Fellow of Indian College of Physicians, FICP, for his contribution to international medicine and emergency care in 1996, and Fellow of Academy of Medical Specialties for his contribution to internal medicine and allied specialties. He has completed advanced training in ICCU and IMCU and has acquired graduate diploma in diabetes care from Newcastle University, Sydney. Doctor has been elevated to the faculty in medicine and diabetology of Newcastle University, Australia for 4 years and a facilitator for the graduate diploma in diabetology. He was awarded Fellow of Indian Society of Cardiology, FISC, and Cardiological Society of India, FCSI. Dr. Balachandran has memberships in several bodies and associations. To name a few are Cardiological Society of India, CSI, Research Society of Diabetes, RSSDI, and International Diabetic Federation IDF, and American Diabetic Association ADA. He has presented research papers in various national and international journals and participated and presented papers in various national and international conferences. He was selected to give Dr. Matthew Ray Memorial Oration in 2014 and a regular guest faculty at various national and local conferences. Now he is the Regional Faculty of Public Health Foundation of India, PHFI at Kollam. His special interests are in internal medicine, emergency care, and cardiodiabetology. Dr. Balachandran was conferred with FRCP, Fellow of Royal College of Physicians, Edinburgh, and recently he was awarded FACC, Fellow of American College of Cardiology. Dr. Balachandran has visited Canada several occasions for conferences and is very familiar to Canada. With all this busy schedule, he finds time to be an active member of Lions Club and participate in all the activities of Lions Club. Doctorne kandale ariyam oru simmathinte look undu. I welcome all our friends who are listening to this program through Zoom and Facebook Live, and for those who will use these recordings from our library in the future. Let me present from Dr. Nayer's Hospital, Kollam, Kerala State, Dr. V. Balachandran, MD, MN, AMS, FRCP, FACC, FICP, FCSI, Diploma in Diabetology and Cardiodiabetology. Dr. Balachandran, ഞങ്ങളുടെ ഹൃദയം തുടിക്കുകയാണ് ഇന്നത്തെ ടോപ്പിക്കായ കൊളസ്ട്രോൾ ആൻഡ് കുക്കിംഗ് ഓയിൽസ്, ദ ഗുഡ്, ദ ബാഡ് ആൻഡ് ദ അഗ്ലി കേൾക്കുന്നതിനായി. നന്ദി, നമസ്കാരം.
അടുത്തതായിട്ട് നമുക്ക് നമ്മുടെ ബഹുമാനപ്പെട്ട ഡോക്ടറെ ഇന്നത്തെ ക്ലാസ്സിൽ ക്ഷണിക്കുകയാണ്. സ്വീകരിച്ച് വന്നതിനുള്ള നന്ദിയൊക്കെ സെന്നോട് പറഞ്ഞു. എന്നാലും ഒരിക്കൽ കൂടെ അങ്ങയോട് സ്വാഗതം പറയാൻ ആഗ്രഹിക്കുന്നു. ഇന്നത്തെ ക്ലാസ് എടുക്കാൻ നന്നായിട്ട്.
Let me share the screen. കാണുന്നുണ്ടോ?
Yes.
Is it okay?
Yes, yes, yes.
Am I audible?
Yes,
Yes, sir.
Yes, sir.
Screen move on undo?
Yeah.
ഇല്ല.
ഉണ്ട്. Everything perfect.
ഇല്ല. It is not moving. Are you able to see the screen?
Yeah. We are able to see. Yes.
Is it moving? Yeah.
Yes.
Mr. President, Mr. Kurian, and Mr. Sen Epan, who introduced me to this audience. So Dave and the members of the Brompton Boat Race and Ontario Malayali Association. In fact, I am really excited, and also it is a dream come true to address Ontario people. Not only I have done it in other places, but Ontario is a special thing for me, because being a diabetologist, this is where Banting and Best, Charles Banting and Frederick Banting and Charles Best discovered insulin in 1920, a Nobel Prize award-winning discovery from Ontario. And it was the greatest discovery of humankind, I can say. And another reason why I'm very much interested is Professor Salim Yusuf, who is also a Malayali from Calicut, one of the greatest epidemiologists, Professor Salim Yusuf, who has involved in many world trials, landmark trials. And he is the one who coined the word migrant Indians. You know, migrant Indian, how the migrant Indians have got more prone to develop coronary artery disease and diabetes. So again, a salute to Professor Salim Yusuf. So my topic is going to be on common topic. It's not, I'm not going to use any major, what do you call it, technical terminologies. Most of you will understand. All of you are very literate people. So the talk is nothing to do with the film acted by Clint Eastwood and Elie Village. This is the good, the bad, and ugly of cholesterol. There are a lot of media reports, a lot of myths are prevailing in the community, media, and so much of things are coming about the anti-cholesterol, anti-statin campaign, and you can eat any amount of eggs, all those things. So the first report came in Scientific American, don't stop worrying about cholesterol. So cholesterol won't do anything. Next one is CNN and IBM said that cholesterol in food is not concern, as a new report says. And again, this is one person called Chris Kresser, the diet heart myth. Cholesterol and saturated fatty acid are not the enemy. So these are all a lot of confusion prevailing among the people. So after this particular book called Big Fat Surprise by Nina T. Cole, this was considered one of the best books in 2014 by The Economist, and Wall Street Journal considered that as the top 10 non-fiction book. And this book, everyone must read it, but forget it. So this again, this book is the one which has created a lot of ripples. And then people started eating, and the incidence of cardiac and heart attack and diabetes started going up. And there's another person who is a protagonist of anti-cholesterol campaign. He is called the Mercola. You can go to his site and see all things which is against for cholesterol, eating and saturated fatty acid and statins, against statins. All those things are there in the site. This is by Mercola and all this. There are about 40 and odd trials to determine whether lowering cholesterol level can prevent heart disease. It's a cholesterol is a factor is of minor importance as a risk factor, but more important is the hypertension, obesity, diabetes, and insufficient physical activity. But cholesterol is of major importance. I'll come to that later, because there are a lot of myths prevailing. Here is a study called Australian Aborigines, where the lowest cholesterol level, but the highest rate of heart disease. But the French people, you have got highest cholesterol level, lowest rate of heart disease. These are all the examples which have been given by these people. So 2015, the US dietary guideline was cholesterol is not a nutrient of concern. Saturated fatty acid is not harmful. Yet can be consumed in good quantity, not a nutrient of concern. So this DGA report that concluded there is insufficient evidence to show that restricting dietary cholesterol lowers low density lipoprotein. So they said that saturated fatty acid is not a nutrient of concern. Hence, stop demonizing saturated fatty acid. They said that it is no significant evidence for concluding the dietary saturated fatty acid associated with increased risk of coronary artery disease or cardiovascular disease. All these things are done by various studies, or they're called various randomized control trial. You can see any number of studies in the literature favoring cholesterol intake. You can see any number of studies favoring cholesterol intake. All these things are sponsored. These are all the proud sponsors of these studies. You can see many more sponsors like this. You can see they all have conflicts of interest. All of them have got conflict of interest. So many nutritional studies are there in the literature, but they are not in the peer-reviewed journals. They are not in the standard textbooks and standard journals. See, there is a study called Interheart study, where it said that they have taken about 9 major risk factors like smoking, fruits and vegetables, a lack of exercise, alcohol, hypertension, diabetes, abdominal obesity, psychosocial factors, and all these things. Lipids forms one of the major risk factors. If all the 9 risk factors are present, then 90% of the people will develop at risk of heart attack in 5 years. So lipids forms a major group of this thing. So what is this cholesterol? It's a Greek terminology. Chole means bile, sterol means stolid. It's a modified steroid. Every animal cell produces cholesterol. It's an acetyl coenzyme, is converted to mevalonate. Glucose is converted to acetyl coenzyme. Even if we take glucose, excess glucose gets converted to cholesterol. So mevalonate, there are about 21 steps by an enzyme called HMG-CoA reductase. Ultimately, the cholesterol is formed. Cholesterol is very important for the system. It builds midbrain fluidity, neurons, myelin sheath, Schwann cells, all steroid hormone, right from pituitary down to your gonads, are made of cholesterol. Steroid hormones are made of cholesterol. Fat-soluble vitamin like ADEC, vitamin A, vitamin D, vitamin E, vitamin K, all have to be dissolved if you have only sufficient cholesterol. Bile contains cholesterol. So the body itself produces about 1000 milligrams of cholesterol. So you don't need to substitute. What you need is only 25 milligram of cholesterol. Body itself is producing 1000 milligram of cholesterol. It gets recycled. It goes excreted in the river, gets absorbed and comes back. So only 25% is substituted externally. Body itself can produce cholesterol by various sources. So the cholesterol is transported in a process called lipoprotein. Don't confuse fat with cholesterol. You have good fats, you have bad fat. When it's sitting on your plate, it is just a plain cholesterol. It only becomes good or bad when it's packed into particles called lipoproteins in your bloodstream. So according to lipid hypothesis, since cholesterol is transported around the body in a form called lipoprotein particles. So the conventional wisdom is if you have a cholesterol, there is increase in LDL particles. So you don't need to measure LDL. If you measure cholesterol, it is the poor man's measurement of measuring the LDL particles. So LDL produces atheroma, that is thickening, hardening of the blood vessels. There is no doubt about it. There are meta-analysis of 16 and odd trials which makes saturated fatty acids were associated with increased LDL cholesterol and decrease in triglyceride. Although saturated fatty acid increase LDL, some reduce saturated fatty acid itself. We have got a lot of difference. There are good saturated fatty acid, bad saturated fatty acid. More important is the LDL particle number. Small dense LDL is more harmful. Diabetic patients have got small dense LDL. That's why diabetic patients are known to develop heart attack. And diabetes is considered as equivalent to a heart attack. If a person has got a diabetes, you treat like a heart attack patients, like in a heart attack who did not have diabetes. So diabetes is called as coronary equivalent. So the Cochrane database is said that stroke, total mortality, all those things are lower if you replace saturated fatty acid with polyunsaturated vegetable oils. We reduce the coronary artery disease. So what Elliot Jocelyn said that from excess fat, diabetes and coronary artery disease begins, and excess fat, diabetes and coronary artery disease die. So after hearing the DGA statement 2013, American College of Cardiology did not know what to do. They just accepted it. Dietary cholesterol does not influence serum cholesterol, but excess is a nutrient of concern. So they didn't want to commit. They did not give an emphatic statement. We don't have any scientific evidence to prove that. Now we have enough scientific evidence to prove that. Now the conventional wisdom is dietary cholesterol increases the risk of heart disease and type 2 diabetes. Now only herbivores get atherosclerosis. Carnivores won't get atherosclerosis. Atherosclerosis means hardening of the blood vessel, blockage of your blood vessel, producing heart attack, kidney problems, stroke, and all that. If you take dogs, cats, tigers, and lions, can be saturated with fat and cholesterol, but atherosclerotic plaque don't develop. How do we differentiate in herbivores and carnivores? These are all the differentiating point. Omnivores will have sharp teeth, claws, and short intestinal tract. They may be panting. This body cooling is by panting, not by sweating. So they lap when you drink fluids, and they produce vitamin C, whereas herbivores won't. We all don't produce vitamin C. Man is a herbivorous. So this is a very important person. We all consider him in a very big esteem, called William Roberts, who was the past president of the American College of Cardiology. He said that elevated cholesterol causes atherosclerosis. It's a protagonist of anti-cholesterol. So atherosclerotic plaques are easily produced experimentally in herbivorous animals. So cholesterol is present in experimentally produced atherosclerotic plaque in human beings. Societies and subjects with high serum cholesterol, LDL, have high frequency of atherosclerotic event. This is called the 7-country study. If you have a high cholesterol, if you have a high LDL, you will definitely have atherosclerotic events. So lowers cholesterol, lowers the incidence. So the only way to produce atherosclerosis is to feed them with high cholesterol and saturated fatty acid diet. No one has produced atherosclerosis by experimentally increasing. If you have high blood pressure, diabetes, and blue and smoker, it's not going to produce atherosclerosis unless you have a bad lipids. So that is very important. Stress is not going to produce atherosclerosis unless your lipid is abnormal. All the multifactorial organs like diabetes, smoking, obesity, all atherosclerosis is not acceptable if the cholesterol level is less than 150, LDL is less than 60. So that is very important. If a person has got LDL less than 60, he will not develop atherosclerotic heart disease, even if you have a hypertension, diabetes. So if you look at it, a level of LDL cholesterol in the plasma 25 milligram would be sufficient to nourish the body cells. You don't need 200 milligram of cholesterol. You don't need 300 milligram of cholesterol. You need only 25 milligram of cholesterol, sufficient to nourish body cells with. So if you look at the infants and toddlers, LDL cholesterol level is less than 30. They don't develop atherosclerotic plaque. And endothelium is a most important dysfunction. Most important part is endothelium. What is endothelium? Endothelium is the inner lining of the cell. Inner lining of the cell is endothelium. Endothelium secretes a substance called endothelial derived relaxing factor or nitroglycerin or nitric oxide. This nitric oxide keeps the cell wall and keeps the, what do you call it, vessel wall intact. So dysfunction of the endothelium occurs due to smoking, hypertension, and diabetes. Even if lipid is bad, atherosclerosis won't occur if endothelium is good. So people with a normal lipid can still have atherosclerotic coronary heart disease if endothelium is bad. So more than 30 million population data from various studies that high LDL causes MI and strokes on death. So there is a paper recently about 2017 European Society of Cardiology said that consistent evidence from numerous multiple different types of clinical and genetic studies unequally establish that LDL causes atherosclerosis. LDL means blood cholesterol. Atherosclerotic cardiovascular disease means inner layer of the blood vessels get blocked. So a consensus statement by European Atherosclerotic Panel, atherosclerosis will not develop if LDL is less than 50 milligrams. So the carbohydrate is the main culprit. It's not the fat is more important. It is the carbohydrate. If we take earlier, it was advised to take about 60% of carbohydrate. Now we ask them to reduce it to 40% carbohydrate, especially a better carbohydrate, not a refined carbohydrate. So reduction of carbohydrate, adding calories, reduce the calories, which is contributed by carbohydrate. So each additional 100 milligram of dietary cholesterol increase the LDL by 2 milligrams. Consuming 1 to 3 egg yolks per day would increase the LDL by 4 to 12 milligrams per deciliter. So there are a lot of cohort studies which proves that there is a 22% increased risk of all-cause mortality, especially in the US physician among men who did not have diabetes, who consumed at least 7 eggs per week. So the same thing we can have. There are a lot of studies which proves that 37,851 men for 8 years and 80,000 women for 14 years with diabetes who consumed even with the lesser eggs, they have high incidence of coronary artery disease. So this is a physician health study and women health study. Most of you would have come across. This is again says that eating large amount of eggs increase the risk of diabetes and coronary artery disease. So this is the scientific. So hence the dietary guidelines with Americans every 5 years it comes. Now we have 2020 dietary guidelines. Is not based on the best scientific evidence available. They just published it. So they misled the public to believe that healthy dietary pattern could contain unlimited quantity of eggs. And though DGAC own healthy dietary pattern allow only 3 eggs per week. So the American Heart Association president, after seeing all the controversies, after seeing all the report and press, they gave an advisory and said that dietary cholesterol is very much a nutrient of concern because it increases LDL, a well-established risk factor. This is the published in American College of Cardiology about the American Heart Association President Advisory. He said that there is now a weight of evidence that plant food, which are very low in saturated fat, are beneficial, can reduce heart disease. Coconut oil is 82% saturated fat. And now recently, all the studies have proved that it raises LDL, the bad cholesterol, as much as butter. Malayalis may not like it, but I'm going to give you all the details about the coconut oil. Dietary guidelines just published recently. So this guideline did not say anything about increasing the nutrient, this thing. They said that limit calories from added sugars and limit calories from saturated fatty acid and reduce the sodium intake. Shift to healthier food and beverage choices. Support healthy eating pattern. That is what the healthy eating pattern is. Fat-free, low-fat dairy, including milk, yogurt, cheese, and fortified soy beverages. These are all the things which have been accepted now even by the latest dietary guidelines for the Americans. So the healthy eating pattern, reduce saturated fatty acid, especially trans-saturated fatty acid. I'll come to that later. Consume less than 10% of the calories per day from saturated fatty acid. What is saturated fatty acid? I'll be talking to you. So there are a lot of press reports stating about the coconut oil. The American Association is misleading the public. There are a lot of reports. Even the cardiologist Salim Yusuf for the blast nutrition guidelines. And then, so the beware of more misinformation from the American Heart. These are all coming in press about coconut oil because Americans now started using a lot of coconut oils. And the effect of coconut oil consumption in cardiovascular disease is recently published 2021 meta-analysis of all the clinical trials. It said that you can see that circulation, one of the world prestigious journal of cardiology, coconut oil may be viewed as one of the most deleterious cooking oil that increase the risk of cardiovascular disease. Even in the comparison with other oils, coconut oil increased LDL cholesterol. Replacing coconut oil with the non-tropical oils will have a health benefit. So this is so what is new? The new about 16 trials, coconut oil consumption significantly increased low density lipoprotein. Although coconut oil consumption also increases high density lipoprotein, but they tried their medium chain fatty acid, it doesn't behave like a medium chain fatty acid. It behaves like a long chain fatty acid called palmitic acid and oleic acid. So there are no evidence of benefit of coconut oil over non-tropical vegetable oil. So this should be, and another thing is association of dietary cholesterol and egg consumption. Again, we have enough evidence recently published March 19, the 2000 articles, dietary cholesterol and cardiovascular disease, scientific advisory by the American Heart Association, which was recently published. And but in Indian data, which says that we have an Indian data, which says that only 2.8% have got an LDL cholesterol less than 50. 11% has got an LDL cholesterol less than 100. Rest of them have got a very high LDL cholesterol, more than 100 or 120, even for the Indians. Because the pure study, they said that LDL is not a risk factor for Indians. That is why a pure study was conducted in 135,018 countries, 5 continents. They said that dietary nutrients and blood level, LDL is not major concern for coronary artery disease in Indians. But you should understand the study conducted by Salim Yusuf was called as the CADI study, coronary artery disease in Indian study, because during 1970s and 80s, several migrant Indians who were migrated from India or Asians who migrated from Philippines and other, they start dying at the age of 50 years, 45 years, 50 years due to premature coronary artery disease. Those people are taken and found out that, imagine a Brahmin from Palghat goes to American US and start eating McDonald's. His system doesn't agree. Maybe it becomes all right for the next generation, second generation or third generation Indians. Majority may be a second generation Indians now. But first generation Indians really suffered during the 1970s and 80s because of the sudden change in dietary habits. And at the time, the concept of cholesterol, LDL, all those things were not there in the 70s and 80s when you people migrated to United States. And high LDL cholesterol, people said that HDL is good. HDL is called the cholesterol acceptor. HDL is called the good cholesterol, but it is not so always. Recently, it published in Barcelona. So I attended the meeting. Conventional wisdom is good cholesterol people have in their blood is better, but it is not so. The mortality rate was 106% higher if the HDL cholesterol is high. If it is higher than 50, it is bad. Lower than 35, it is bad. So 35 to 70 is ideal. If it is more than 75, the mortality is high. Less than 35, mortality is high. But rising the HDL cholesterol by various methods, only way to raise the HDL cholesterol is by exercise and reduce the saturated fatty acid. This is the only way to raise the HDL cholesterol. By raising the HDL cholesterol, the coronary artery disease mortality does not improve. It has been said by the Reduce IT trial and recently concluded a few trials which said that raising the HDL cholesterol doesn't improve the coronary artery disease mortality. So, but a lot of things are involved. Why the Keralites are compared to other people, when you take cholesterol, it doesn't affect much to the Keralites, but it affects the migrant people. So especially people who migrated from other states, migrant people who migrated to, there are a lot of study called CADI study. One is called as coronary artery disease, by Indian study by Salim Yusuf et al. And then there is a South Hall study in United Kingdom, and there is a South African study and Singapore study, all migrant Indian. Migrant Indians have got 8-fold increase in risk of coronary artery disease and diabetes. Even gestational diabetes, there is an 8-fold increase in risk of gestational diabetes. So genetic is very important. If your father is diabetic, mother is diabetic, your father has got strong family history of coronary artery disease, you have got every chance of getting a coronary artery disease. Racial, you have a racial, you can see the Pima Indians. The classical example is the Red Indians or Native Americans, the Pima Indians. They were hunter-gatherers once upon a time. They get food very rarely. And then now that most of them are executives, they're merrymaking. Every day the food is available in plenty. The plenty is, that is the reason why the Pima Indians, the incidence of coronary artery disease and diabetes are 90%. You can see the incidence of glucose intolerance in Red Indian, and that is Native American, is about 90%. They are the best ethnic group to study. Like that, you have got Chinese, Japanese people. This is called a Japanese paradox. Japanese, they are high waistline. They have got heavy smokers. They consume alcohol. Their waist hip ratio is very high. Their BMI is very high. Still, the incidence of coronary artery disease is less because their eating habits are different. They eat a lot of seafood. Whereas the same thing, Mediterranean people, they eat a lot of drinks. They smoke a lot. Their waist hip ratio is high. But still, their incidence of myocardial infarction is less. But like that, we have Asian Indian paradox. Asian Indians, we are all Asian Indians. Asian Indians, we have got low BMI, but our waist ratio is high. Our intra-abdominal fat is much higher compared to the extra-abdominal fat. As a result, our triglycerides are high. Our cholesterol may be normal, but we have high incidence of diabetes and coronary artery disease, which is called as Asian Indian paradox. So the racial is important, ethnicity important, geography is important. I'll tell you one simple example. We have in southern part of Kerala, from Alappuzha to Manavala Kurichi, all of you know, we have a very good belt of radioactive material, uranium, thorium, plutonium, titanium. So many rare minerals are being taken. This is the only place in the world, next is Western Australia, where you have rich radioactive materials. But the local people doesn't get affected. Migrant people, there are a lot of genetic variations. There are a lot of people who go in for cancer, and the study has been conducted, but it is not published for various reasons. So this LDL is low, but HDL high and small dense LDL matters. Diabetic patient, if you measure the LDL is normal, but the proportion of small dense LDL is high. That's why diabetes, they develop more heart attack compared to the non-diabetic. We see the LDL metabolism. LDL normally gets internalized by an enzyme called PCSK9, but internalization of LDL may be impaired. So a lot of things are HDL and amount of HDL in the system that determines the person whether he gets heart attack or not. Non-HDL particle, a lot of things are important. Triglyceride is important. Apolipoprotein B and apolipoprotein A is important. We have a lot of invisible fat in the diet. It's not the ordinary fat, it's an invisible fat in the diet. I'll come to that. There is a statin war. There are a lot of media report about against statins. They're asking people not to take statins and for cholesterol. It is they are misleading the public. There is an anti-statin lobby. European Heart Journal recently published that anti-statin lobby strikes again. Time to set records straight. If you stop statin, yearly statin discontinuation increases with the negative statin-related news stories associated with increased risk of myocardial infarction. If you stop statin, the incidence of coronary artery disease becomes 4-fold high, and they start developing acute myocardial infarction. So statin is a lifelong drug. I used to tell the patients, diabetes is a lifelong disease, coronary artery disease is a lifelong disease, and cholesterol is a lifelong disease. You have got to take the drugs lifelong. And we have got a lot of media reports in the press about against statins. So there are a lot, why, I don't know why there is a statin. Statin is the biggest pharmaceutical market in the world after metformin, because that is the reason why people are against statins. And there are a lot of anti-cholesterol drugs. Nobody talks anything about it. But all the drugs fails to reduce the cholesterol. Only statins is the only one reduce the cholesterol. Reduction of cholesterol is not important, but statin stabilizes the plaque. It has got a lot of pleiotropic benefits. Statin has got a lot of pleiotropic benefits. Never ever stop statins, because statins stabilizes the plaque. It makes a rupture-prone plaque into a non-rupture-prone plaque. So that's why the statins are very important in managing, even if your cholesterol has come to normal, never stop statin, at least take in small amount, because the stopping statin is more harmful than continuing statins. So this is the guideline. If a person has got a coronary disease, they've got a high incidence statin. Can cholesterol drug fight COVID? Yes, we have enough evidence to show that lung cells are not designated to hold fat. There are a lot of fat in the lung cells. That is the reason why COVID, when it affects the lung, people with a high cholesterol, they behave badly. So the virus is dependent on glucose intake, cholesterol production, fatty acid oxidation. Now we have fenofibrate is being tried even in COVID patients. So what is this cholesterol? We have three types of cholesterol. What is called as LDL cholesterol, which is called as bad cholesterol. HDL cholesterol, which is called as good cholesterol. Triglyceride, which is called as dirty cholesterol. Triglyceride as such won't produce problem, but when it is associated with LDL cholesterol or diabetes or coronary disease, it produces problem. So the fat type of fat is matters. We have a lot of long chain fatty acid and short chain fatty acid. If you look at the fatty acid, we have saturated fatty acid. It is thick, solid, increase the total cholesterol. It is present and increase the LDL. It is present in ghee, butter, and coconut oil. Polyunsaturated fatty acid. It lowers LDL, lowers HDL also. Safflower oil, sunflower oil, soybean oil, corn oil, all contain polyunsaturated fatty acid. Monounsaturated fatty acid. Metabolism, the best. Metabolically is the best. Elevated HDL, it lowers LDL. That's what we want. Olive oil, called as Mediterranean oil. That's why people in Mediterranean country, they don't develop much heart attack. That's called as Mediterranean paradox. Mustard oil, commonly used in the eastern part. Groundnut oil and ginger oil in the central and western part. That's why ginger oil is called as the nalla ennai. That is oil good for health, because it contains equal proportions. There is another fatty acid called trans fatty acid, which is very bad. I'll come to that. So the saturated fatty acid means it contains no double bonds. It is totally saturated. It donates cholesterol. It is present in all the US diets of cheese, pizza, dessert, all the beef and all the heavy animal fat. Collectively, these contribute about 31% of the saturated fatty acid consumed. Saturated fatty acid is harmful, whereas saturated fatty acid taken from the dairy product are slightly better and it can be allowed in moderate quantity. They are considered good saturated fatty acids. The meta-analysis of over 60 trials, higher intake of saturated fatty acid were associated with increase in LDL and decrease in HDL. And though it's only single bonds, it least reactive chemically. So saturated fatty acid. Unsaturated fatty acid, if you have one double bond, it is called as monounsaturated fatty acid. If it is multiple double bond, it is called as polyunsaturated fatty acids. There is another fat called trans fatty acid. It's an artificial fat produced due to hydrogenation. All hydrogenated oil, all refined, double refined oil contains trans fatty acid. Animal fat like margarine, vegetable fat like vanaspati, they are highly harmful because they contain trans fatty acid. Worst type of fat linked to coronary disease, risk doubled with 2% increase intake, whereas saturated fatty acid, you have to take 15%. So 15% of saturated fatty acid is equivalent to 2% of trans fatty acid. Worse than saturated fatty acid, lowers HDL and increase the LDL. It produces Alzheimer's, cancer, diabetes, obesity, liver dysfunction, infertility, and depression. All the fast foods which we see in the roadside contains trans fatty acid because they repeatedly fry the oil. They don't change the oil. Next day morning when they say they add the new oil on top of old oil and repeatedly they fry the oil. Even in Kerala when they make chips, they don't remove the old yesterday's oil and throw it. They just put the new oil on top of it. New oil also becomes bad. So this trans fatty acid is metabolized in the liver. It is not regulated. It does not produce glycogen formation. It is bad for health. So repeatedly heating oil is bad. Deep frying oil, that what happens, it burns all the oxidative mechanism. There is a lot of oxidative stress. The oxidative stress produces atherosclerosis, hypertension, all the repeated oil produces a lot of smoke. It is bad to the lung because the smoke point is less. So it produces a lot of smoke. Never ever repeat the oil. You can use once or you can use for the second time, and third time you have to throw it. Palm oil was once promoted as in India, because if you look at the Lay's chips which you see, in American, the Lay's chips are made in lapseed oil or canola oil, whereas in India, the Lay's chips are made in palm oil. It is bad. So that is why Americans, they saved themselves in producing all the chips and all the even the McDonald's items are produced in rapeseed oil and canola oil. But here we have used a lot of palm oil. It is very bad. Palm oil consumption increases LDL cholesterol. I'll tell you why it is bad. So olive oil, definitely there is a study called PREDIMED study. It's a Mediterranean oil. There is a risk of cardiovascular disease comes down. So this is about the palm oil. And so mustard oil is rich in alpha linoleic acid. It is good. It is contained MUFA. It is better than sunflower oil, and it is good for cooking. But the smell is may not the South Indians and the western part of India, they may not like the mustard oil, and as well as the olive oil. So there is one thing called omega-3 fatty acids, called as N3 fatty acids. Human cannot manufacture, so you have to get it from the food. The best food is the eicosapentaenoic acid or docosahexaenoic acid. It is coming from the fresh water. So that's why it is called as Greenland effect. People in Greenland, they don't develop heart attack because they consume a lot of omega-3 fatty acids, oil fish. But in vegetables, you have mustard, canola, rapeseed, turnip, all these things contains omega-3 fatty acids. The omega-6 fatty acid, it's got a high smoke point. If you put it, immediately a lot of smoke comes and it surrounds you and you may have to inhale it. It contains a lot of oxidative stress. All the polyunsaturated fatty acids are omega-6 fatty acid like canola and safflower. So this is most important, the N6-N3 ratio. Remember this, wherever you go and buy an oil, look at the N6-N3 ratio. The ratio should be around 5:1. Many are eating a ratio more than 20:1. So the best oil of N6-N3 ratio is mustard oil, canola oil, gingerly oil. Corn oil, safflower, canola, peanut butter are the worst because they got a very high N6-N3 ratio. Groundnut oil and olive oil, okay, because reasonably around 10:1 N6 ratio. And that's why the gingerly oil is called the oil good for health. And oryzanol is another antioxidant found in rice bran oil. It's a good oil and for us for cooking. And antioxidant property, it reduces the plasma cholesterol absorption, early atherosclerosis, inhibit platelet adhesiveness. Platelet is the one which produces clot. Once you reduce the adhesiveness, the platelet clot comes down and your heart attack, stroke or renal problem will come down. Tocotinol is another antioxidant. It belongs to vitamin E family. We all know vitamin E is good. It's an antioxidant. It prevents cardiovascular disease and cancer. Reverse the atherosclerosis. And tocotinol is present in several oils. And there is another thing called phytosterol. It's another antioxidant. It is analogous to cholesterol, structural component of cell membrane, rich in vegetable oil like wheat germ oil, sesame oil, canola oil, almond oil, and all that. Good antioxidant. All the refined oils are bad because they are done by crushing of the steel, heated to temperature between 110 to 180, deguming, neutralization, and bleaching. Free radicals are there. Oxidative stress is very high. Butylated hydrotoluene and anisole are added. It's a bland oil. It's mild flavor, free from impurities, but it turns rancid and it produces smell if you for recooking, recooking, it is bad. All the refined oil should not be cooked again. Unrefined oil is the best. You know, the chekku process of pressing the seeds, the conventional method of extracting oil. It's available in Kerala, several places. There's unrefined oil. Health-wise, unrefined oil are the best due to the presence of bioactive compounds and vitamin E content. The rancidity is the one, the disagreeable odor, which many may not like it by some of the oils like olive oil and mustard oil. The smoke point, you always look at the smoke point. All the refined oils have got a low smoke point because they emanate smoke. All the reused oil emanates smoke. And some of the oils like PUFA containing oils like sunflower oil, safflower oil, they all emanate smoke. Whereas gingerly oil and groundnut oil, they don't do much. They are the best. So this is what I was mentioning about the omega-3 fatty acids. You have got omega-6 and omega-3. If we take omega-6, they are pro-atherogenic. That means it produces hardening of the coronary artery and blockage of blood vessels. Pro-thrombotic, it produces clot. Pro-oxidant, it contains a lot of oxidative stress. Vasoconstrictive, it constricts the blood vessels. Whereas if you take N3 fatty acid, it's less atherogenic, less thrombotic, oxidative activity is there, and produces nitric oxide. Nitric oxide is a vasodilator. It dilates the blood vessels. So this ratio is important. The oils, a lot of oils are there. You see that olive oil, canola oil, lapseed oil, the saturated fatty acid content is less. PUFA content is more. Whereas soya bean, sunflower oil, the PUFA content, N6 is very high, N3 is low. So the ratio of soya bean and sunflower oil is high. So if you take it, if you look at the next, this thing, there is a ratio. If you look at the safflower oil, which is called the canola, kurdi seeds, sunflower oil, corn oil, all the oils, they've got a very high N6, N3 ratio. It is bad. N6, N3 ratio, I told you, WHO, I said that it should be around less than 20:1. Here the ratio is 146. If you take pure sunflower oil, it is nothing but toxic. So you can, sunflower oil, safflower oil, they reduce the cholesterol, but a lot of oxidative stress. It produces a lot of oxidative materials, and it is not good. It is pro-thrombotic, pro-atherosclerotic. So the ratio should be brought to the minimum. How do you break the ratio? You have to mix it with other oils. Coconut oil, we'll come to that later. Other mustard oil has got a best ratio, and buffalo ghee, deshi ghee has got a good ratio. That's why in those days, people were using quite a lot of ghee along with other oils. So they are antioxidants. At the same time, N6, N3 ratio is less. So the best oil, heart-friendly oil, according to American Diabetic Association, and people all over the world agree, is the mustard oil, because it contains low saturated fatty acid, high MUFA, moderate PUFA, N6, N3 ratio is 1.2 to 1.1. Rapeseed oil or canola oil is same as mustard oil. It is recommended by ADA, and American Diabetic Association, and American Heart Association. It is same proportion. N6, N3 ratio is good. Olive oil is called as Mediterranean oil. It is anti-thrombotic, vasodilatory, anti-inflammatory. It's why they get the Mediterranean paradox. Gingerly oil, it's oil which South Indian is usual lot. It's called the null and all of them are not equal proportions. And good, you can take it. It's a friendly oil, groundnut oil, because it has got a high smoke point. You can easily fry. It is good for frying, deep frying. So it is an unrefined oil, it's always good. Corn oil is a plant oil, hence there's no cholesterol. So it is good. American Heart Association, risk is less, different from animal fat. It contains medium chain triglyceride. It is reasonably better. Rice bran oil is another very good oil. It's extracted from germ and inner husk of rice, high smoke point. But it can emanate smoke. High smoke point, you can use it as for deep frying, more balanced oil, and rich in vitamin D. All the antioxidants are present. So another not bad, because all of them are reduces the cholesterol. But soya bean oil, sunflower oil, safflower oil. But you high N6, N3 ratio, you have to supplement with other oils like what I said earlier. So the oils have to be mixed to get a desired effect. So all these things are called the non-tropical oil promoted by the Western countries or Indians. But Indians started developing insulin resistance during the last 20 years. That's the reason incidence of diabetes and coronary artery disease have gone up in India, because of the large consumption of this oil. But it should not be consumed alone. It has to be consumed along with a little bit of ghee, along with rapeseed oil or canola oil or rice bran oil or gingerly oil. Coconut oil, it is 90% saturated. It produces atherosclerotic cardiovascular potential. It's very high with coconut oil. But it again, the ethnic group, Mexico, they use coconut oil. South Americans, they use coconut oil. There's not much of problem. Kerala, they use coconut oil. The incidence of cardiac disease are high, diabetes is high, but it is not alarming proportions. Not good at all, not safe at all, palm oil. It is highly saturated fatty acid, increase in N6, N3 ratio. In fact, US FDA has banned it. There's a cottonseed oil, it's contained myristic oil and palmitic, that is long chain fatty acid. So high PUFA, it contains a lot of pesticides, a lot of toxins are there, should not be used. Vanaspati is the worst of all. More shelf life. It is. It can keep it any number of months and years. It is not good for deep frying because it got a low smoke point. It is the unhealthiest oil and poisonous. Recently, US FDA has banned all the trans fatty acid oils. And in fact, they have given guidelines to the food industries not to use trans fatty acid oil. So we have forgotten that we have taken a lot of oil, what is called the invisible oil. The food items which you take, contains a lot of oil, or a lot of staple cereals, millets, milk contains oil, pulses, and in fact, the fish contains 21% is oil. West Bengal people take a lot of oils, and meat and egg contains little amount. Coconut, we consume large amount of coconut, especially in Kerala, and then in all of them, we have lot of invisible oil in the diet, and which we don't measure. So dietary cholesterol should be included, the oil which is invisible in our normal day-to-day diet. So what are the undisputed facts? We all know that reheated or recycled oils are harmful. No single oil is good enough. That is definite. Any oil is bad, but total amount of fat should be brought down less than 25%. So all the three oils must be mixed: saturated fatty acid, polyunsaturated fatty acid N3, polyunsaturated fatty acid N6, and MUFA. All must be 10%. All must be in equal proportion. Virgin oil is always better. That is, oil comes from the checker. The trans fatty acid are not heart healthy, and it has been banned by various countries. Controversial is definitely saturated fat. It's really harmful. This is where all the media hype is there on saturated fatty acid. Yes, we have some good saturated fatty acid. Choose that and take it, because high saturated fatty acid is harmful only when they have coronary artery disease, only when they have diabetes, only when they have cardiac failure. If you take 3 or 4 eggs a day, the cardiac failure gets worsened, coronary artery disease gets worsened. Whereas all these things are not there, the family is not there, history is not there, eating eggs is not that harmful compared to, because they contain a lot of saturated fatty acid. Is coconut oil healthy or not? Maybe it's population-based, ethnicity-based, and all those things we have to still, lot of studies have to undergo, because the studies are all come from Western countries. Though they have done in native Indians, and though they have done in India and Singapore, but the studies are mainly from Western countries. A lot of studies have been done in Kerala, but they are not full of case control study, because it is very difficult to conduct a study on a nutrition. If Salim Yusuf has done a study on Ramipuril, it is very easy. Pill bottle technique, the compliance guidelines, we can easily measure how this drug acts. We can measure the drug levels, but it's not possible to do a very good case control, double blind, and studies on nutrition. The contemporary issues are reused oils and adulteration. A lot of adulteration going on with a lot of petroleum products are there. So this is what, in conclusion, there is definite evidence to prove that dietary cholesterol recommendations should be restricted. Dietary cholesterol is a nutrient of concern for some people, especially people who have got coronary artery disease, cardiac failure, and diabetes. Advice against consumption of refined grains and sweets in favor of foods with greater nutrient density. Dietary protein as we can eat a lot of millets. Dietary protein as a macronutrient of choice. It gives you a lot of macronutrients. From old carbohydrate-based diet, now we advise low fat diet. Now we advise moderate protein diet, shifting to better fat, moderate protein, and low carbohydrate diet. So most important, the lifestyle modification. We see a lot of reports in the social media. We always learn medicine from the standard textbook of medicine, like Harrison's textbook of medicine, or New England Journal of Medicine, American Journal of Cardiology, or British Medical Journal, or Lancet. But please use the media to report positively on statins and cholesterol lowering for the benefit of your patient and society as a whole. So a lot of media reports, everybody writes it. He said that I consume 10 eggs a day for the last 10 years, nothing happens. Nothing will happen, because it all depends upon your endothelium. It all depends upon your genetic makeup. So if we say that smoking is bad, compared to normal individual who has got a risk of 7% heart attack, smokers have got 27.5% heart attack. It does not mean 73% don't develop heart attack. It does not mean they are not the example. This is a smoking has got about 7-fold increase in risk of developing a heart attack. That is how we have to look into that. So don't believe all the social media and on statins and cholesterol and saturated fatty acid. Still, cholesterol is a big nutrient of concern, dietary cholesterol. Of course, the systemic cholesterol, LDL is definitely, we know LDL is the main determining factor for atherosclerosis. So don't believe the social media. The good part of cholesterol is an essential nutrient required by every single cell of the body. Serum cholesterol is necessary for every steroid hormone. And third, the cholesterol helps to convert sunlight to vitamin D in the body. You all must get enough vitamin D. That is one of the very important advice I give it to all the people in Canada. And the important thing is the vitamin D. Even in people who are in Bihar are vitamin D deficient. Most of the people in Bombay, even though we have a sunshine, where they are vitamin D deficient because the sunshine, ultraviolet B rays doesn't come to the earth. It stops there because of the pollution, atmospheric pollution. So vitamin D is one of the very important, the safest vitamin D in the world is the vitamin D. And vitamin D is the only vitamin which is useful. If you don't take vitamin B, vitamin C, all those things, it doesn't matter. Vitamin D is harmful after a particular age. Vitamin A is harmful after a particular age. Vitamin D can only say vitamin which protects every system and organ of the body. It's called a sunshine vitamin, for which you need cholesterol. All of you must, especially the temperate climate, must fortify their food with vitamin D, or must take at least 60 lakhs units of vitamin D once in 3 weeks. That is the reason why all these Scandinavian people come to Kerala, where they are in Goa or any of the eastern countries like Philippines, Phuket, and they stay there for 7 to 8 days, have enough sunshine for 8 hours. If they get enough sunshine for 6 hours for a period of 10 days, they get 6 months store of vitamin D. So that is the reason why they come here and get their sunshine. It's a sunshine vitamin D. It is vitamin ultraviolet B is important, whereas Gulf countries have got sunshine. They contain only ultraviolet A rays, that is called a shorter wavelength, that produces skin cancer. That is one of the reasons why the Gulf people, they wear the robes to prevent skin cancer. Male people, they wear the white, and female, they wear the black robes because of to prevent them from getting ultraviolet A rays. So this is the good aspect of cholesterol. The bad aspect of cholesterol, conventional wisdom is lipid hypothesis. Dietary cholesterol, yes, it's a nutrient of concern. LDL less than 50, no atherosclerosis. Saturated fatty acid is still bad, but we have good saturated fatty acid. Trans fatty acid is the worst. Saturated fatty acid should be replaced by CUFA and MUFA, more polyunsaturated, monounsaturated. Replacing saturated fatty acid with carbohydrate is not good. Carbohydrate should be replaced with saturated fatty acid. Carbohydrate also you have good and bad. So reduce from 65% to 45%. Coconut oil is still a nutrient of concern. The controversy continues. Invisible fat form 40% of Indian diet. If all these things, if the endothelium is good, no atherosclerotic cardiovascular disease, you don't need to worry about your fat as long as endothelium is good. And the ugly part is influence of food industry on nutrition. The anti-cholesterol, anti-statin lobby. Irresponsibly on the part of social media, internet, Facebook, or WhatsApp, create confusion in the mind of common man. Doctors also forward such messages without giving a fitting reply. Plenty of reports were increase in sudden death and fresh coronary artery disease when statins are stopped. Never hesitate to stop statins. So lastly, we have 3 gorgons. In Greek mythology, the gorgons are called as demon, Stheno, Uriel, and Medusa. So one is saturated fatty acid, another is small dense LDL or non-HDL or high carbohydrate. So always to be minimum and be afraid to all these 3 gorgons. And this is the last Egyptian proverb. 1/4 of what you eat keeps you alive. The other 3/4 keeps your doctor alive. Thank you, sir, for your kind, patient listening. If you have any questions, I'm free to answer. You can unmute and shoot your questions.
Yeah, question, go ahead.
Korean.
Any questions? Please go ahead.
Yeah, there is one question, doctor.
Yeah.
Do you recommend chelation therapy for clearing the blocks?
Cheliation.
Yeah, we read in social
Palliative
media.
therapy or cheliation therapy?
Chelation therapy, CHELATION.
There is no scientific proof. Everything must be. So you know about after seeing the vaccination, you know how difficult to bring out the product. If a product comes, it takes about 4 clinical studies. Phase 1, phase 2, phase 3, phase 4. It takes about 10 years for the product to come to the market. We are all there for the phase 3 and phase 4 and post-marketing. After the product comes to the market, at that time, again, the post-marketing surveillance is there. So that much is there. Even after coming post-marketing surveillance, several products have gone out of the market. You have seen so many of your antihistamines have gone out of the market because it started producing some of the cardiac problem. All these things are only gimmick. You can see there are a lot of extra counter pulsations. That is, people give some counter pulsation technique to improve the coronary perfusion. To a certain extent, excess, but not is the treatment of choice. If you have a block, then only you can have a medical management. If a person has got a continuously unstable pain, unstable block, the only thing is intervention. Intervention is always patient-centric. It is always disease-centric. It's not the patient choose. It is the disease which chooses. You can go in for a pulmonary rotablation. You can go in for a angioplasty or a stent, or you can go in for a bypass surgery. It is technically defined.
Thank you.
Any other questions?
Doctor, my name is Jatin. This is always a question that I've thought of asking to doctors. What oil do you use at your house, so that we can kind of take a leaf out of it and then try to adopt that?
We use oils very, very limited. In fact, my wife doesn't allow. And the amount of oil, what we use is nothing but rice bran oil and gingerly oil. These are the 2 oils we commonly use. I take a little bit of ghee. So these are the 3 which we use. So my cholesterol is always low. It is around 80 LDL or 75 LDL. But still, a person can develop heart attack because if the endothelium is bad, if there is strong family history, all those things can have developed. I told you, the genetic, environmental, ethnic, your stress, all these things can lead into a heart attack and diabetes. It's not the lipid only. Lipid is a major factor. It's not, we have other factors also.
Thank you, doctor.
Any other questions? Questions വിശ്വസിക്കുന്നു. അടുത്തായിട്ട് വോട്ടർ താങ്ക്സ് ആണ്. വോട്ടർ താങ്ക്സ് പറയാൻ ക്ഷണിക്കുന്നതും ഞങ്ങളെല്ലാം ഇവിടെ യോഗ ചെയ്യിച്ച് ഞങ്ങളുടെയൊക്കെ മെന്റൽ ഹെൽത്തിനെ വളരെ ഊർജ്ജസ്വലമാക്കി തരുന്ന ഞങ്ങളുടെ കമ്മിറ്റി തന്നെ ഒരു അംഗമുണ്ട്. അദ്ദേഹത്തിൻ്റെ പേരാണ് ദേവപ്രസാദ് സ്വാമി. അദ്ദേഹം ഇന്ന് വോട്ടർ താങ്ക്സ് പറയാൻ ഡോക്ടർ പരിചയപ്പെടുന്ന നല്ല ആളാണ്, യോഗയുടെ ആളാണ്. അദ്ദേഹം ഞങ്ങളുടെ ഓൺ യോഗ ഡോക്ടറാണ്. ഞങ്ങൾക്ക് ആവശ്യമുള്ളപ്പോഴൊക്കെ സമാധാനം വേണ്ടപ്പോഴൊക്കെ പുള്ളി ഞങ്ങളെ മനസ്സിനെ എങ്ങനെ നിയന്ത്രിക്കാന്നൊക്കെ പറഞ്ഞു തരും. അപ്പം അദ്ദേഹത്തിന് ഞാൻ ആദരപൂർവ്വം ഇന്നത്തെ വോട്ടർ താങ്ക്സ് പറയാനായിട്ട് ക്ഷണിച്ചോളൂ.
പ്രിയ സുഹൃത്തുക്കളെ, ഇന്ന് വളരെ എൻറിച്ച് ആയിട്ടുള്ള ഒരു സബ്ജക്റ്റിനെ കുറിച്ച്, അതായത് നമുക്ക് നമ്മുടെ ജീവിതത്തിൽ അനുദിനം ആവശ്യമുള്ള ഒരു സബ്ജക്റ്റിനെ കുറിച്ചാണ് ഇന്ന് ഡോക്ടർ ക്ലാസ് എടുത്തത്. അദ്ദേഹത്തിൻ്റെ ക്ലാസ് വളരെ നന്നായിരുന്നു. വളരെ വ്യക്തമായി, വളരെ സയൻറ്റിഫിക് ആയിട്ട്, എവിഡൻസോടുകൂടി, പ്രൂഫോടുകൂടി, വളരെ എക്സ്പേർട്ടായിട്ടാണ് അദ്ദേഹം ഈ ക്ലാസ് അവതരിപ്പിച്ചത്. അത് നമുക്കെല്ലാവർക്കും വളരെയേറെ പ്രയോജനമാണ്. നമ്മുടെ അനുദിന ജീവിതത്തിൽ നമുക്ക് പ്രാവർത്തികമാക്കാൻ പറ്റുന്ന രീതിയിലുള്ള നമ്മുടെ ഹെൽത്തിനെ ബേസ് ചെയ്തുകൊണ്ടുള്ള ഒരു തീമായിരുന്നു ഇന്നത്തേത്. അത് വളരെ ഭംഗിയായിട്ട് അദ്ദേഹം അവതരിപ്പിച്ചു. അദ്ദേഹത്തിൻ്റെ അവതരണത്തിൽ തന്നെ നമുക്ക് മനസ്സിലാക്കാൻ സാധിക്കും അദ്ദേഹത്തിൻ്റെ പ്രാവീണ്യം. എന്തുമാത്രം അറിവും വിജ്ഞാനവും ഉള്ള ഒരാളാണ് അദ്ദേഹം എന്ന് നമുക്ക് മനസ്സിലാക്കാൻ സാധിക്കും. അപ്പോൾ അതുകൊണ്ട് ഞങ്ങളെല്ലാവരെയും വളരെയേറെ എൻലൈറ്റൻമെൻറ്റിലേക്ക് കൊണ്ടുവന്ന, അതായത് ആരോഗ്യപരമായി നമ്മുടെ ഭക്ഷണ രീതിയിൽ ഏതെല്ലാം രീതിയിലുള്ള ഓയിലുകളൊക്കെ ഉപയോഗിക്കാം, അപ്പോൾ അത് എങ്ങനെയാണ് ഉപയോഗിച്ചാൽ ഏത് രീതിയിലാണ് നമുക്ക് നമ്മുടെ ആരോഗ്യം നിലനിർത്താൻ സാധിക്കുക എന്ന് വളരെ വ്യക്തമായി ക്ലിയറായിട്ട് പറഞ്ഞു തന്ന ഡോക്ടർ ബാലചന്ദ്രന് ഞങ്ങളുടെ ഹൃദയം നിറഞ്ഞ നന്ദി രേഖപ്പെടുത്തുന്നു. പിന്നെ നമ്മുടെ ഈ പ്രോഗ്രാമെല്ലാം എപ്പോഴും അതിൻ്റെ ജീവനാഡിയായിട്ട് പ്രവർത്തിക്കുന്ന മിസ്റ്റർ കുര്യന് ഞങ്ങളുടെ എല്ലാവരുടെയും ഹൃദയം നിറഞ്ഞ നന്ദി ഞാൻ രേഖപ്പെടുത്തുകയാണ്. പിന്നെ ഇന്ന് നമ്മുടെ കൂടെ വരാമെന്ന് ഏറ്റിരുന്ന രാജശ്രീ നായർക്ക് അവരുടെ ഉള്ളിൽ നമ്മുടെ കൂടെ കൂടണമെന്നുണ്ടായിരുന്നു, ആഗ്രഹമുണ്ടായിരുന്നു. പക്ഷേ അവരെയും നമുക്ക് കൂടാൻ സാധിച്ചില്ല. പക്ഷെ അവരെയും നന്ദിപൂർവ്വം ഓർക്കുകയാണ്. പിന്നെ വെൽക്കം സ്പീച്ച് നടത്തിയ സെൻ ഈപ്പന് പ്രത്യേകം നന്ദി പറയുന്നു. ഡോക്ടറിനെ കുറിച്ച് പഠിച്ച് അദ്ദേഹത്തിൻ്റെ റിസർച്ചിനെ കുറിച്ചെല്ലാം മനസ്സിലാക്കിയതിന് ശേഷം അദ്ദേഹത്തെ ഇൻട്രൊഡ്യൂസ് ചെയ്ത് ഞങ്ങൾക്ക് എല്ലാവർക്കും വളരെ ഉപകാരമായി. അദ്ദേഹത്തിൻ്റെ നോളജിനെ കുറിച്ച് നമുക്ക് മനസ്സിലാക്കാൻ സാധിച്ചു. അതുകൊണ്ട് പ്രത്യേകം നന്ദി രേഖപ്പെടുത്തുന്നു. പിന്നെ ഈ കൂടെ പങ്കെടുത്ത എല്ലാവർക്കും ഇതിൻ്റെ ഭാരവാഹികൾക്ക് എല്ലാവർക്കും ബ്രാഹ്മണൻ മലയാളി സമാജത്തിൻ്റെ നാമത്തിൽ എല്ലാവർക്കും ഒരിക്കൽ കൂടെ നന്ദി, നമസ്കാരം.
Thank you. യോഗേഷ് ഇല്ലായിരുന്നു.
ഇല്ല, ജോലിയാ യോഗേഷ്. പിന്നെ നമുക്ക് ഡോക്ടറെ ഇന്ന് അറേഞ്ച് ചെയ്ത ഡോക്ടറെ നമ്മുടെ മായ റേച്ചൽ തോമസ്, യോഗേഷ് അവർക്കുള്ള പ്രത്യേക നന്ദി കൂടുതൽ അറിയിക്കുന്നു. പറഞ്ഞിട്ടില്ല.
Thank you.
Thank you, doctor. Thank you again for joining us and keep class.
We'll meet in Ontario.
Yeah, sure. Yeah. When you come back again?
Well, I came to Montreal and Toronto a couple of times.
Oh, I see.
We'll come to.
So when you come soon again, or?
Well, a major conference is there. Ontario doesn't host any major conference.
Oh, I see. Okay.
In Vancouver or Toronto or Montreal.
Oh, I see. Okay.
Next Olympics is in Montreal.
We have big water Olympics here in Brampton. It's coming on August 21st. It is one of the biggest festival in Canada, actually. This kind of, yeah.
Thank you. Very nice. I'll leave.
Last 11 years we are doing this.
Thank you.
Okay.